Hello, I'm Hannah Donner with the Collaborative on Health and the Environment. Change is bringing you the latest environmental health science through a partnership, calls, webinars, science serves, publications, and social media. I would like to welcome everyone to today's webinar titled Racial Ethnic Differences in EDC Exposures. This webinar is sponsored by the HEEDS, Young EDC Scientists Showcase, and the CHE EDC Strategies Partnership. Our moderator today is Sarah Howard, founder and manager of diabeteenvironment.org. We will leave time following the presentations for a brief Q&A session. You may type in questions through the Q&A feature available in the menu bar at the top of your window at any point during the presentation. After the presentation, our moderator will read out questions for our speakers to respond to. We will get to as many comments and questions as we can during the Q&A period. For those of you who called in on the phone, we have posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. The webinar is scheduled to last for 45 minutes and is being recorded for our call and webinar archive. With that, I'll turn things over to you, Sarah.
Thank you, Hannah. I'm Sarah Howard. Everyone, welcome. This webinar is part of a series called the Young EDC Scientists Showcase, which is the acronym for that is YES. It's sponsored by HEEDS, which stands for Healthy Environment and Endocrine Disruptor Strategies. And we are sponsoring it together with CHE, the Collaborative on Health and the Environment. And today this webinar is also co-sponsored by the EDC Strategies Partnership, which in addition to CHE and HEEDS, also includes the Commonweal Biomonitoring Program and HEAL, which is the Health and Environment Alliance. So we started this series as an opportunity for early career scientists to present their research. And this is the third webinar in the series. The recordings of the other two are available on the website at heeds.org or CHE's website, which is healthandenvironment.org. And if you want to sign up for announcements of future webinars, you can go to heeds.org and sign up for the HEEDS newsletter. So the topic today is racial and ethnic differences in EDC exposures. We're hoping to have two speakers followed by a question and answer period that I will moderate. Our first speaker is Marissa Chan. She's currently studying towards a Master of Science in Environmental Health at the T.H. Chan School of Public Health at Harvard in the James Todd Lab. And I just want to mention as a side note that next week, Dr. James Todd will be speaking on another webinar on environmental reproductive justice, which you can also find at CHE's website. So Marissa's research interest and work experience focuses on the intersection of place-based environmental hazards and exposure to endocrine disrupting chemicals in personal care and consumer products. Our second speaker is Brandy Smith. She's currently a doctoral student at the University of Illinois at Urbana-Champaign in the informatics program. Her research focuses on understanding how phthalate exposure in menopausal women affects health outcomes. And she uses machine learning approaches to tackle this issue. All right, so Marissa, I believe we are ready. And I will take questions at the very end after everybody's finished. Okay.
Hi, everyone. Thank you for the great introduction, Sarah. My name again is Marissa Chan, and I'm a second-year Master of Science student in the Department of Environmental Health. And first off, I just wanted to thank Alyssa for inviting me to present today, as well as Sarah and Hannah for help with the details and logistics of the presentation. And today I'm going to be discussing a scoping literature review that I worked on with a few members of the James Todd Lab titled Racial Ethnic Disparities in Early Life Exposure to Endocrine Disrupting Chemicals Commonly Used in Personal Care Products. So just as a brief overview of the presentation today, I'm going to start with a background into endocrine disrupting chemicals, which I will refer to as EDCs in this presentation, and go on to discuss some differences in exposure. I will then move on to talk about the methods of our scoping literature review and the results, and then end with future research recommendations and conclusions. So just as a first brief background into EDCs, they're defined as exogenous substances that interfere with the body's hormonal processes And these can either be naturally occurring or synthetic chemicals. And EDCs are used in a variety of personal care and consumer products, and they're really added for their desired properties, such as some are preservatives, antibacterial agents, as well as ingredients of fragrance. Some common EDCs in personal care products are phthalates, and specifically low molecular weight phthalates, and parabens. And these, like all EDCs, have kind of distinct chemical structures and mechanisms of action. Many EDCs in personal care products are also ubiquitous in our environment, and studies have reported detection frequencies for common EDCs greater than 90%. So now kind of just expanding this discussion to focus on early life exposure to EDCs. First, just some context. In this presentation, I'm going to be referring to early life as the prenatal period, but in other research and discussions, they consider early life up until early childhood. And we're specifically focused on early life because the prenatal period is a critical window of development, and it is vulnerable to a wide range of exposures. Studies have shown that exposure to early life EDCs have been linked to a variety of adverse maternal and child health outcomes, including but not limited to birth weight, gestational age and preterm birth, glucose intolerance, and gestational diabetes. And studies are also linking personal care product use to health outcomes later in life, such as obesity, early onset of puberty, neurobehavioral outcomes, asthma, and allergic disease outcomes. So adding to kind of the complexities surrounding this issue, there are racial and ethnic differences in both exposure and outcomes. And personal care products are an important source of many EDCs and have been hypothesized to be a risk factor for the environmental health disparities that we're seeing. In terms of exposure, patterns of personal care product use differ by race, ethnicity, and this is potentially due to cultural or social drivers. A number of studies have evaluated EDCs commonly used in personal care products as it relates to race and ethnicity, and specifically they've examined hair care products, skin care products, cosmetics, nail polish, perfumes, and vaginal douches. But these are predominantly in non-pregnant populations. And so really at the core of this work, the EDC-associated health outcomes, which I described in the previous slide, are found to burden certain populations, and predominantly women of color. Just to give a couple examples, Black and Asian women are 2 times more likely to have a low birth weight infant, and Asian and Hispanic women have a higher prevalence of gestational diabetes. And these are both compared to the reference population of non-Hispanic white women. And so as I've kind of outlined, there are 2 areas of research in terms of exposure to personal care product chemicals containing EDCs and the negative maternal and child outcomes. But really there's a gap focused on the intersection of EDC-associated product use and health outcomes that has not yet been explored. And so our lab really examines the range of these issues, and we recognize the need for a scoping literature review to see what research there is out there and what is missing. So moving on to our scoping literature review, we had 3 main aims. The first was to summarize the literature that examines early life exposure to 8 chemicals or classes of chemicals, which were identified based on prior literature as chemicals of concern, and specifically among women in the US and Puerto Rico. Second, review articles that report stratified data on early life exposure to these 8 chemicals, but their studies were not predominantly focused on examining these disparities. And lastly, we wanted to provide recommendations for research needed to really fill the gap in the literature on EDC-associated personal care product use. So we created and applied this search strategy that looked at 4 databases from the time of database inception through March 2020. And this strategy was designed and executed by a librarian at Harvard who has expertise in conducting scoping and systematic reviews. For the search strategy, we looked at research examining the exposure to 8 chemicals of concern that we already discussed kind of during the prenatal period, and specifically looking at biomonitoring studies. These studies had to be US-based and report chemical concentrations by race and ethnicity. And finally, we excluded animal studies. In terms of the databases we used, we looked in PubMed, Embase, Web of Science, and the Cochrane Central Register of Controlled Trials. Next, moving on to the results, I'm going to briefly go over the number of articles we identified and then dive more into the two different categories of articles that were included in this review. So this is a diagram of each phase of the process in terms of identifying articles for this scoping review. As discussed, we looked at 4 databases, which provided almost 2,500 articles. Around 1,000 were duplicates and were removed. And from there, we were left with 1,539 articles that went through the title and abstract review. About 191 went through the full text review from there. And then in the end, we included 3 articles in the tier 1 category, meaning that they explicitly examined racial and ethnic differences in product use. And if you remember, that's our first aim from the literature review aims. And next we had 53 articles that reported stratified results by race, ethnicity, but it was not their objective to examine these differences. And that was our second aim. So for tier 1 articles, which were again our primary aim from this review, there were 3 articles from 2 cohorts, and these articles were published from 2017 to 2019. And to briefly summarize the main findings, the highest metabolites in both cohorts were in MBP, MIBP, MBZP, and MEP metabolites. And these are all metabolites from low molecular weight phthalates, which are the class of phthalates that are found in personal care product chemicals. In the life codes cohort, this was among non-Hispanic Black and Hispanic women, as well as women who reported other. And another interesting thing was that they reported that MEP decreased for Hispanic women in late pregnancy, while increased for non-Hispanic Black women. And this may point to different patterns of product use or potentially changing perceptions of risk throughout pregnancy. In the MUSC study, non-Hispanic Black women had higher concentrations compared to non-Hispanic white women. So now moving on to the tier 2 articles, there were 40 that examined stratified exposure data, but did not aim to examine these differences between groups. This is just the first half of the tier 2 phthalates. I just split them up onto 2 slides because of space, but amongst these, the majority of the articles were focused in the CCCEH cohort, as well as the Chamacos cohort. And both of these are racially homogeneous cohorts. But there were a couple that reported results in somewhat more diverse cohorts. And because these studies did not aim to examine disparities, we highlighted when they compared chemical concentrations to women of reproductive age from NHANES, which is a national representative health survey, as kind of a way to get at differences, even though we do recognize that it is difficult to make comparisons or draw conclusions from this. And from these studies, everything was either generally comparable or no comparisons were made to NHANES women. These were the 5 remaining phthalate articles, and there were 5 remaining cohorts. And these were reported among a range of different cohort populations. 2 of them, the PROTECT cohort, which is in Puerto Rico, and the Healthy Start cohort reported higher concentrations of measured chemicals compared to NHANES. And one important thing to comment on is that some of the higher metabolites among the Healthy Start cohort are high molecular weight, meaning that they are predominantly used as additives and plasticizers and not specifically in personal care products. And so we've made it through the phthalates, and I'm now going to continue on with the tier 2 phenol articles. There were 17 articles that presented stratified data on exposure to phenols, and specifically parabens, triclosan, and benzophenone 3. And we're seeing a lot of the same cohort names, which is in part because some of the studies examined both phthalates and phenols, so they were included twice in these tables. But it really is also due to the fact that there is a select number of cohorts that really collect data on this specific type of environmental exposure. And again, we're seeing similar heterogeneous results in terms of higher, lower, or similar concentrations compared to women from NHANES. And this is the final table of phenols, and 2 populations, the PROTECT cohort, which I mentioned in the tier 2 phthalates, as well as a population recruited from Brooklyn Prenatal Clinic, reported higher concentrations compared to NHANES. And these were both among populations of color. So what do we really do now? I've shown a lot of tables, but what does it really all mean? And as unsatisfying an answer as this is, it really illustrates the need for additional research and the lack of research in this area. And again, to just highlight the main finding, only 3 studies explicitly examined racial ethnic differences in personal care product associated EDCs. So we identified a few specific areas that need additional research, and I kind of say a few, but there's clearly a long list, so this really illustrates the areas of research still in need. First, we suggest increased research examining early life EDCs as a risk factor for disparities in the health outcomes that we're seeing. Next, examining PCP chemical exposure in racially, ethnically diverse populations to really understand product use among some understudied populations, such as women who report other or Asian women who are understudied. We also suggest the inclusion of results stratified by race ethnicity when reporting EDC concentrations. And next, the examination of early life exposure to PCP chemicals that have not been studied. So again, we found results on phthalates and phenols, but the remaining chemicals of concern did not have any epidemiologic literature. We also suggest considering the assessment of personal care products and other sources of EDCs in the same studies to really understand the degree to which these sources contribute to disparities. And last but not least, we recommend examining the social, cultural, and socioeconomic determinants of disparities in exposure and how they really interact with race ethnicity. So coming to the conclusion, what I hope you gained from this presentation is an understanding of the lack of data and research examining disparities in personal care product associated EDCs out there. But I really hope you also gain some opportunities in terms of research needed, as well as some ideas, hopefully, for your own research. And I kind of glossed over the comment on cultural and social drivers, but in the end, I really want to emphasize how this differential product use is linked to historic systems and discriminatory practices that reward lighter skin and straighter hair. So there's this notion that product use and beauty is skin deep, but these chemicals are really being found to impact biological systems, and they may contribute to these negative health outcomes that we're seeing. So future research is really just one piece of the strategy in terms of interventions. And other necessary and needed pieces are policy, education, and community engagement, but that really is a discussion for another day and another presentation. So just ending finally with acknowledgements, I really want to thank my entire lab for their support, but specifically Dr. James Todd, Dr. Emma Preston, and Carol Mita, who really helped with this review and guided me along the way. And also Ayana and Mikaya, who helped me look through the 1,500 articles. I definitely could not have done it without them. Here are just the references for my presentation. And that is it. Thank you so much for your time and listening today, and feel free to reach out if you'd like to talk about any specific portions of this project or this field in general. I would love to talk more with you about that. And just a comment that I think I forgot to mention at the beginning, this paper is still currently under review. So if you look it up, you won't be able to find it at this point in time. That's it for me. Thank you.
Great, thank you so much, Marissa. And Brandy, thank you for joining us. I know you were having some technical problems, and so take your time. I have your slides, Brandy, if you'd like me to bring them up for you. Brandy, are you able to hear me?
Yes, can you all hear me?
Yes, we can hear you, great. Do you want me to pull up your slides and you can just cue me through, or are you okay pulling up your own?
I can pull up my own, yeah.
Okay, great. Welcome. Just be a moment. While we're waiting for Brandy to pull up her slides, I'll remind our audience, if you want to put questions into the Q&A box, we'll get to as many comments and questions as we can afterwards. And feel free to start adding your questions now, but we'll have a Q&A session after the second presentation with Brandy. It'll just be one more moment.
Okay. Can everyone see the slides?
Yes, we can see everything. Thank you, Brandy.
Great. Sorry, I was having technical difficulties. And I'm happy that I'm able to join now. And I am so excited that you all invited me to speak at the Young EDC Scientists Showcase. I'm an informatics PhD candidate at the University of Illinois Urbana-Champaign. And today I will be presenting some preliminary results from a study looking at the effects of phthalate exposure and health disparities on reproductive health outcomes at midlife. Uh-oh.
If it's not, there
Okay.
you go.
So midlife is a critical and understudied period in life, and it corresponds to the ages of 40 through 59. It's at the intersection of growth and decline, growth in emotional well-being and life experience, and decline in physical and mental health. This also is a critical period for women because they experience menopause. And we know that there are a lot of factors that can contribute to menopause. One of those being endocrine disrupting chemicals, which are chemicals that can alter, mimic, or block hormonal action, as well as health disparities, which are negative systemic health outcomes that occur in marginalized communities. Menopause is also a natural occurrence that at midlife that's associated with several symptoms. There are a lot of them listed here today, but for the purposes of this slide, I'm just going to focus on hot flashes because it's the most occurring symptom, and about 7 out of 10 women report experiencing hot flashes during menopause. So phthalates are a type of endocrine disrupting chemical. They are found in a lot of different products, but exposure at midlife occurs through cigarette smoking. So phthalates are a component of cigarette smoke. They can also be exposed to phthalates through cosmetic and feminine care products, as well as hairstyling products. And phthalates have been shown in the literature to be associated with earlier age at menopause, sleep disturbances, as well as the occurrence of experiencing hot flashes. Disparities also occur in phthalate exposure. Now, there's a lot of literature that shows that phthalate exposure disparities occur at earlier reproductive ages and not at midlife. And the literature has shown that Black women who use have increased uses of personal care products, and thus they have a higher burden of exposure to phthalates. And especially a phthalate called DHP from the overuse of feminine care products. There's also a lot of literature that shows that Black pregnant women have increased levels of urinary phthalate exposures, and we know that, and through the literature, it is known that through this phthalate exposure at pregnancy, that it can possibly have the children of these women can have developmental issues in life. So just to summarize and kind of give the purpose and significance of this study, there's not many studies that look at environmental hazards and health disparities, especially in midlife. Phthalate exposure has been shown to be associated with experiencing hot flashes. This is very important because this is one of the most common symptoms during midlife in women. And then Black women tend to have a higher burden of phthalate levels, but we don't know if this is also significant at midlife. And then phthalates are an exposure, but they're also a mediator when we're looking at the relationship between health disparities and hot flashes. So this is just a conceptual model that we plan to adopt to complete this analysis, looking at health disparities and hot flashes as a health outcome. And I'll talk a little bit more about what these variables are, but conceptually, this is just a way that we can look at exposure as a mediator. I mean, phthalates as an exposure and a mediator, as well as looking at some confounder of the exposure to kind of understand the relationship between health disparities and hot flashes. And also, because we are not exposed to phthalates one chemical at a time, but actually as a combination of chemicals, they're called phthalate mixtures. we want to also be able to simultaneously apply some method to control for collinearity of those phthalates. So for our study, we're going to use the Midlife Women's Health Study, which is a longitudinal study following women over about 7 years. These women are between the ages of 45 and 54. They're from the Baltimore, Maryland area. And the study was initially conducted to look at the risk factors of hot flashes during midlife. So the women were given a questionnaire where they filled out information related to their demographics, health, and other factors. And the women also had 4 follow-up clinical studies where they gave urine as well as blood serum samples to be able to look at um, chemical levels in the urine as well as hormonal information through the blood serum. So this is just a general characteristics of the Midlife Women's Health Study. About 65% of the women in the study were white, about 31% were Black, and less than 6% were of some other ethnicities such as Latina or Asian. Majority of the women fell into a higher income level bracket. So majority of them were over 50,000 or more income. So it's a pretty affluent study. This was further seen with the education level of the women. About a little over 80% of them had at least college training or postgraduate training. So back to that conceptual model that we're planning to adopt from a previous study. So it's a way to look at multiple mediators, and when we're looking at a health disparity and health outcome model. And for the purposes of this study, we're going to be looking at hot flashes as our health outcome. And in the questionnaire, the question that was proposed to be able to look at this health outcome was, have you ever experienced hot flashes? And the answer could have been yes or no. So it was a binary outcome. And then our X in our conceptual model is our race. So this is our health disparity factor. And then our exposure is phthalate mixtures. And then the confounding factor that we want to focus on is smoking status. And so that is our B within this conceptual model. So we conducted a chi-square test of independence to look at the relationship between hot flashes and some other categorical variables. So we looked at race and income because these are 2 factors that can be related to health disparities. Smoking status because it's our confounding factor within the conceptual model, and then menopausal status just because it's relevant to this group of women. So smoking status as well as menopausal status are both significantly related to ever experiencing hot flashes, which pretty much made sense. It's pretty intuitive. That makes sense. But about 84% of women who ever experienced hot flashes were former or never smoked, and about 62% were perimenopausal, 38% were premenopausal. But to sum all of this up, this kind of just showed us that we should probably be looking at menopausal status as well as a potential confounding factor within this model. We also wanted to look at and kind of justify whether phthalate levels were higher in Black women in this group. And so there were 10 phthalate metabolites in the study, and out of those 10, about 4 of the metabolites were higher in Black women compared to white women. And before, when I kind of talked about the phthalate exposure and how Black women have a higher burden of a particular phthalate called DHP, it's kind of justified here because we see that the metabolite MEHP, which is a metabolite of DHP, was higher in Black women in this group. And in our conception, in our model that we plan to use for our analysis, we want to be able to control for collinearity of metabolites, of the phthalate metabolites. And so I conducted just a principal component analysis to see if we can be able to reduce the number of metabolite variables that we have in the study. And so out of the 10 metabolites, we see that they cluster to about 3 principal components, which are shown here in orange, red, and green. And so that shows us that we're able to actually control for that collinearity with this particular type of analysis. So to conclude, we definitely want to be able to consider menopausal status as a confounding factor within this analysis. We want to stratify by those confounders, but we know that it could possibly introduce bias into the model. In the future, we would definitely like to look at other covariates to be able to draw more inferences, but this could be a little difficult because of the proposed mediation analysis that we hope to apply. And then this is an important study because we're able to identify modifiable risks such as smoking and as well as use of certain products that can be attributed to phthalate exposure. And then in the future, we hope to apply the mediation analysis coupled with the principal component analysis to control for collinearity when looking at the phthalate exposures. We also hope to look at more robust models for collinearity. And also we would like to look at other health outcomes regarding this group. And we also want to stratify by race to be able to actually identify what factors may be different between the different ethnicities. And this is just a word cloud that I generated in R from all of the literature that I read. So I just put this here as just a big picture, but it's not anything really significant. And I would like to thank all of my committee members, Dr. Rebecca Smith, who was my advisor, Dr. Jody Flaws, who was influential in the Midlife Women's Health Study, Dr. Diana Grigsby Toussaint, and Dr. Alexander Lipka. And I'd like to thank the Collaborative on Health and the Environment for inviting me to speak at the seminar, the participants of the Midlife Women's Health Study, and my funding source, which is the Interdisciplinary Environmental Toxicology Program. And now I'm open to any questions.
Thank you, Brandy. So if people have questions, I will moderate them and I'm going to read them off from the Q&A feature so you can type them into there. And we already have a few from Marissa, so I'm going to start with those. And actually one of them is one that I had too. And two of us were wondering how much of the EDC disparity research is coming from inside the US versus in other countries?
Yeah, that is definitely a good question. For us, we specifically focused on US-based studies just based on patterns of product use, so the cultural and social drivers I kind of referred to, as well as there's different countries have different chemical regulations for personal care products, so different countries have different chemicals in the same products. So there definitely is literature outside of the US. I unfortunately can't speak that much to it because we focus specifically on US-based studies, but there is some available literature out there.
Okay, and so one person is wondering how and why did you decide to limit to the 8 chemicals found in personal care products?
Mm-hmm. Yeah, we specifically focused on those 8 based on some prior literature. So some examples that I can think of offhand are from Dr. Russ Hauser and Dr. Antonio Califat, as well as Dr. Erica Chow, Dr. Robin Dodson. There's just kind of a few articles that have examined and highlighted how these are specifically chemicals of concern. Yeah, so it was based off prior literature that are kind of some founding or foundational literature in this field that have driven kind of this question in this field forward.
All right, and one more for Marissa, then I'll move to Brandy. Were your studies also controlled for socioeconomic status?
That is a good question. In terms of the tier 1 articles, they were controlled for SES, but the tier 2 articles, since they didn't explicitly look at these disparities, some of them were not. So it really had to be if SES was a covariate or confounder within the study's research question.
And Brandy, I don't know if you can see the Q&A, but I will read it out to you. It said, what do you make of the fact that the Black women in the study population were of higher SES, but still had more phthalate exposure compared to white women?
That's a very good question, and I'm not entirely sure. Um, we can assume that they use more personal care products overall than white women. Um, but that's the only answer I can give now. I'm not entirely sure. It would be interesting to further look at that in this population to see why that is. So I'll definitely jot that down to be able to better answer that in the future. But yeah, the only thing we can assume is that they're using more personal care products than white women.
Yeah. And then maybe this one might apply to both of you. So do you know what groups are monitoring effects of exposures and effects on public health outcomes?
I can go first. Yeah, I was thinking through this question when I saw it, and I think there's a bunch of different levels. So just on the federal level, we have like NHANES, who is the Nationally Representative Health Survey, who collects this data and also collects health outcome information. But there's also some statewide programs. I'm from California and I went to undergrad in California. So the California Safe Cosmetics program does examine a lot of the exposures in terms of what's in personal care products. And I think a lot of this work, though, interestingly, is done at organizations in terms of institutions. So in my lab, Dr. James Todd's lab, our work is kind of focused on this, as well as I know there's some really interesting work by Dr. Ami Zota at George Washington, and kind of some interdisciplinary work from one of my other mentors, Dr. Bhavna Shamasunder at Occidental. And then at a different level, there's also a range of nonprofits who are doing a lot of work around this. A few that I can think of are Environmental Working Group. I came from an organization called Black Women for Wellness in Los Angeles, as well as Breast Cancer Prevention Partners in California. So that's kind of a whole, I know that it's multi-layered, but there are kind of a different array of institutions and organizations doing this work.
Yeah. Brandy, do you have any to add to that?
I actually don't have anything to add to that. I'm more on the data analysis side, so I kind of just I read as much as I can, but I don't really get into it a lot. But yeah, pretty much what some of the organizations that she said, I've heard of them through the literature and everything. But yeah, so
okay. Also, so Brandy, someone asked, the occurrence of MMP metabolites appeared very bimodal in both racial groups. Did any of the other variables in your study explain that variation?
So we haven't looked at any other variables yet to see if they do explain that variation, but that would be something to look at in the future. So this is a very preliminary analysis. So those are preliminary results. I haven't looked at anything else yet, but it was interesting to see those histograms and those distributions and try to figure out what could be contributing to some of those distributions that we're seeing. But at the moment, we are not sure of what variables could be contributing to that.
All right, and then either of you, is it known if personal care products marketed toward women of color have different amounts of endocrine disrupting chemicals than those marketed to whites, maybe?
I've read a recent review by Dr. Zota, and she does talk a little bit about how there's more marketing toward Black women. I don't know per se if the products have more endocrine disrupting chemicals, but they are marketed more toward Black women. So maybe they just use them more. But yeah, maybe Marissa can talk a little bit more about that because she deals with that more exclusively. But that paper, I know for sure, details how Black women are targeted more through marketing.
Yeah, I was going to say a very similar thing. Black women, unfortunately, are targeted more in terms of marketing. And there is some research that I can think of. Dr. Robin Dodson at the Silent Spring Institute has looked at endocrine disrupting chemicals and asthma-associated chemicals and finding higher amounts in products. They are marketed towards Black women, so kind of connected to that. So yeah, I support everything Brandy just said.
All right, and another question that could probably go to either of you. Do you know of any data on indigenous populations and where this group fits into EDC exposure research?
I think that's a really good question, and it's a huge gap in this type of research and literature. There, there kind of currently is a focus on products used by non-Hispanic Black women, Hispanic women, and non-Hispanic white women, but kind of everyone else is either lumped into other, or the data isn't disaggregated enough for us to examine it. So I currently don't know of any, but I definitely think that is an area of further research.
I agree. Looking at the health disparity research, mostly it's between Black and white women, and like you said, Marissa, other ethnicities or other races are lumped into another group, and so you can't really get any significant inferences from those groups. So it's definitely something that a gap that needs to be filled in the literature. So definitely agree.
All right, well, thank you. We don't have any more questions, so unless anyone has a final question they want to submit real quick, we could wrap this up. And I would just like to thank both of you for speaking. It was really interesting. Oh, actually, we got one more. We'll just throw this out. I'm curious if you or any of your collaborators have looked into disparities in metabolism of these EDCs.
Yeah, that's a good question. I personally don't know specifically focused on metabolism of EDCs.
Yeah, none of my collaborators, to my knowledge, are looking at metabolism of EDCs. So that I'm not aware of that one. So that is a good question, though. I think something very interesting to look into.
All right, here, we're getting more questions. Okay, are there EDC and consumer product use study among men or trans populations?
Yeah, I think that's another huge gap in the literature. I really don't know of any, and it's really unfortunate because I think people assume like, oh, if you identify as a man, you're going to use less products. So there's kind of these classifications which may lead to research in certain populations, but not some in others. So I really appreciate these questions kind of highlighting additional areas that I might not have discussed in my presentation or have really considered.
All right, we got a last flurry here. How would you recommend that someone who's interested in the subject get involved in reducing disparities? That's a big one.
Would you like to take that one first, Brandy? I can't, but I don't want to.
That is a very big question. I actually feel that the research that I'm doing is a very good way to, to get involved in health disparities work. But as far as hands-on or boots to the ground approaches, not entirely sure. That's something that I definitely should look more into, because definitely an important topic.
Yeah, I would definitely agree with that. I think some of the nonprofit organizations that I mentioned are great organizations that are doing a lot of this work. But if you're kind of on the research side, I think one of my suggestions was including stratified data by race ethnicity. And that's kind of like a little step, but in terms of people who are working on health disparities issues, it does help, I believe. So I think there are kind of a range of different ways to get involved. I'm happy to talk more about it also offline.
And how about policy implications? That's a related question somebody asked about.
Yeah, I have a lot of thoughts on policy.
We may not have time.
Yeah, I have a lot of thoughts. I think there's kind of two sides to that personally, in terms of ensuring that our governmental organizations are strong in the fact that they are protecting public health. So on that realm of things, but we also have to work on the social side of things. So in California, in a few states across the US, they have passed the Crown Act, which is to ban discriminatory practices based on hair in the workplace and schools. So I think there kind of needs to be work on both sides of these issues in terms of policy.
I definitely agree. Couldn't have said it better. this research that we are doing is definitely a preliminary step to help policy change. Definitely agree.
Okay, great. Thank you. I think we're going to have to shut it down now. Someone does ask if people can contact you for information after. I would say if you email Che, we can forward questions on that way, if that's possible. Anyway, Hannah, I'm going to turn it over to you, and thank you, Marissa and Brandy, for speaking. That was great.
Great. Yeah, anyone can email me at hannah@healthandenvironment.org if you would like to get in touch with Marissa or Brandy about their work. And with that, I'd like to thank everyone. Thank you, Sarah and Brandy and Marissa. We're approaching the end of today's webinar. A video recording will be available on Che's website soon, and tomorrow you'll receive an email containing a link to the video. The next Che Partnership webinar will take place next week, November 18th, and is titled Environmental Reproductive Justice, Racial Disparities in Environmental Pollution and Chemical Exposures. This will be the second webinar in our new series, Generation Chemical, How Environmental Exposures Are Affecting Reproductive Health and Development. To learn more into RCP, please visit our website at healthandenvironment.org. If you are new to Che and would like to stay updated about upcoming events or more, please sign up to receive our newsletter by selecting the Join Us tab at the top of any page on our website at healthandenvironment.org. Additionally, if you appreciate these Che Partnership webinars bringing you the latest environmental health research for free, we encourage you to support Che's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers, Marissa and Brandy, for your excellent presentations and for taking time to present today. And to you, Sarah, for your excellent moderation. Thank you so much for joining us. Stay well and healthy, and have a great day.